Hey there, this is Ari Whitten, and in this presentation, I'm going to be talking to all of you about adrenal fatigue and is it actually real? So we're going to take an evidence-based look at this concept, this theory of adrenal fatigue to find out if it's real. This is a project I've been working on for over a year now. It originally started many years ago when I first kind of started looking at this evidence, and then it's really been in the last year that I've put the pieces together and done a comprehensive analysis of all of the scientific research that's related to this concept. That is, I believe, by far the most comprehensive analysis of the research that's ever been done. And I haven't actually published it yet. This is something that I've just completed. So you guys are getting the first look at all of this for the first time that I'm presenting it to the world. This has been a labor of love for me for many, many months. This has been a huge amount of work to actually comprehensively analyze this entire body of evidence over 20 years of research. And I hope you guys enjoy this. I think that it will bring a lot of clarity for many of you. It might anger some of you. It might validate some of you. So I don't know exactly what every one of your reactions is going to be, but either way, I think you'll find this analysis of the research to be fascinating, and I think you're going to take a lot from it. So real quick, just about me. I am an avid outdoors person. I've been studying health since I was 13 years old, very seriously. I was reading college level nutrition textbooks by the time I was 14. I had kind of an early gift for the science in this area, and it's been a passion of mine for over 20 years now. And for the last several years, I've been working with a lot of the top experts, researchers, physicians in the fields related to chronic fatigue. And I've really been trying to build out a comprehensive science of what are the factors that lead to fatigue, and what does the evidence say about the best paths to recovery, what needs to be done in order to recover from chronic fatigue. And for the last 3 years, I've also been actively working with many people with chronic fatigue. I have a group of over 2,500 people who have chronic fatigue that I've worked with over the last couple of years. And I have a very vibrant, active Facebook group with those members. And it's been an absolute passion of mine, an obsession of mine. And what you're about to get in this presentation is kind of the latest insights of the latest projects that I've been working on. So with that said, adrenal fatigue. I'm sure most of you have heard of this concept. And you probably also know that it's a very popular theory and kind of idea among holistic or alternative health practitioners. And you probably also know that it's rejected by conventional MDs. This is not a legitimate, accepted medical condition among mainstream MDs. So what's the truth here? And what I'm about to present to you is an analysis of all the evidence that's related to figuring out whether this concept actually has truth or not. So again, in the natural health community, we've all been told this narrative of adrenal fatigue and how our adrenals get fatigued due to chronic stress. And as far as why I developed an interest in this, believe it or not, a few years ago, I actually had the idea to write a book that was basically an evidence-based guide to adrenal fatigue. And I saw all of these conventional MDs basically brushing off the whole concept of adrenal fatigue as nonsense. And so I said, I'm going to, look at the evidence, and I'm going to scientifically prove, I'm going to find all the evidence that proves that adrenal fatigue actually is a legitimate science-based condition. And I'm going to put it all together in a book. So that's the project that I originally embarked on. And basically it was many, many months of digging into all of the research on this subject that links cortisol levels and fatigue. And after doing this, I really was kind of at a loss because the evidence, and as you're about to find out in this presentation, is extraordinarily contradictory. There is just no clear consensus about what the heck is going on as far as any adrenal or HPA axis dysfunction that is occurring in relationship to chronic fatigue. So at this time, I really had just kind of figured out, okay, well, actually my assumption about this, that there was strong evidence in support of these ideas that was going to back it up, was actually wrong. And I had to kind of encounter that. And at the time, I was really a proponent of adrenal fatigue, and I really believed in this. I had been teaching it for many years, and I'd read lots of books and articles about it. So I was assuming it was completely legitimate, and my intention was to prove it scientifically. And basically, I found that in order to prove it scientifically, I would have had to do a lot of cherry picking of the research. So I just kind of let it sit there. And then more recently, in the last 6 months or year, I've revisited all of that research with basically a new goal, which is I don't want to prove anything about my preconceived notions. I just want to find out what the science actually says. And I want to put the whole body of evidence, every single study that has ever been done related to the relationship of cortisol levels, HPA axis function, and chronic fatigue. And I want to present that body of evidence to the world so that they can figure out for themselves whether this concept of adrenal fatigue is legitimate or not, and whether we should really be focusing on the adrenals in chronic fatigue or not. So basically, I discovered that my assumptions were wrong. So real quick, what is adrenal fatigue? Again, I'm sure most of you already know this stuff. So common symptoms that are said to be associated with this idea of adrenal fatigue: obviously fatigue, depression, anxiety, brain fog, low blood sugar, waking up tired after sleeping 7 or 8 hours, cravings for certain kinds of sugary, salty foods, trouble sleeping, things like that. And then we know that there's kind of these 3 phases, and many different people break it down into different phases depending on who you talk to. And have lots of different, very scientific looking graphs for the different phases, and 7 phases. And, in each phase, they say the hormones do this, this, and this. As I'm going to show you, none of that is actually scientifically backed. There's really no support for very well-defined phases with specific hormonal abnormalities that relate to specific symptoms. But this is the basic idea, first this initial state of high cortisol, then it kind of dips back down, and then the adrenals get exhausted. So here's the deal. There's really no science on adrenal fatigue, and that's a really big problem. So when I'm talking about the fact that I'm doing a comprehensive analysis of all the research, because there's no research on adrenal fatigue specifically, we have to look in other places. And I'll show you what I mean. Basically, if you go on PubMed, you do a search for any particular condition: psoriasis, Alzheimer's, diabetes, lung cancer, depression, whatever it is, you're going to find at least dozens, probably hundreds or thousands of studies that have been done related to that condition. Now, if you do the same search for adrenal fatigue, and feel free to do this right now while you're listening, you can go on to PubMed, do a search for adrenal fatigue, and you'll basically find nothing. I mean, literally almost nothing. And what you do find, it's actually worse than nothing, because what you do find is actually negative data. You'll find this literature review, which is similar to the one that I've done, but I think mine is more comprehensive, which basically concluded that there's no substantiation for that adrenal fatigue is an actual medical condition. Adrenal fatigue is still a myth. The title of this systematic review is "Adrenal Fatigue Does Not Exist." So again, basically no research whatsoever on adrenal fatigue, but many related studies that we can look to. So there's actually over 20 years of research examining the relationship between 3 other recognize legitimate fatigue syndromes and adrenal health, HPA axis function, and cortisol levels. So is there a link between chronic fatigue and cortisol levels? That's the simple question that we're trying to analyze in this research. So these three conditions that are recognized go by a few different names: burnout syndrome, vital exhaustion, and chronic fatigue syndrome, fibromyalgia. I'm lumping those together for our purposes here because some of the research explores both simultaneously, and these conditions are often lumped together because they share so many symptoms. So we can look at these three, or arguably four, different conditions because there's lots and lots of evidence of research that has actually examined HPA axis function, cortisol levels, and the relationship of that with these syndromes. So real quick, symptoms of burnout syndrome, just so you can see there's a lot of overlap in the symptoms of burnout syndrome relative to the symptoms claimed for adrenal fatigue. Vital exhaustion, overlap here, though there's less symptoms overall that are listed here. And then chronic fatigue syndrome. And this is an interesting one, and I'll show you why. This was a really interesting piece of kind of light research, I guess you could call it, or survey, that was conducted by actually an adrenal fatigue website. I think it was called adrenalsolution.com. And this is a proponent of adrenal fatigue, by the way. And what he did was he took data from a CDC survey on people with chronic fatigue syndrome. And basically that data essentially just asked all these people with chronic fatigue syndrome, do you have this symptom? Do you have this symptom? Do you have joint pain? Do you have headaches? Do you have fatigue? Do you have problems with sleep? Do you have brain fog? Do you have, sore throat, et cetera, et cetera? And they compiled percentages of, the amount of people with chronic fatigue syndrome who are reporting that they do suffer from this symptom, whether sleep or brain fog or muscle pain or whatever it is. Okay, and so you see that data here. Now, what the guy at adrenalsolution.com did was he basically polled his audience of people who were either diagnosed with adrenal fatigue or suspect that they have it, kind of self-diagnosed, and just asked them the same list of questions. Do you suffer from this symptom? Do you suffer from this symptom? Do you suffer from this symptom, etc.? And this is the result that he came up with. And it's a remarkable result because, as you can see, the percentages of people who are diagnosed with adrenal fatigue or self-diagnosed, people are reporting basically the same exact symptoms in virtually the same exact percentages. Okay. There are slight differences in some of these, but you get the idea. Here's some more symptoms. These are the second. So these are the primary symptoms, and these are the secondary symptoms. So you can see that the percentages are almost identical. Now, this is an important thing because we almost never hear anyone talking about the relationship of chronic fatigue syndrome to adrenal fatigue. Usually a person is either operating in a paradigm where they look at these types of symptoms as chronic fatigue syndrome, they label them as that, or they label them as adrenal fatigue. But there's almost nothing online, nothing written of anyone really examining, okay, what actually discerns these two conditions? How different are they? Are they really different conditions? There's really almost nothing written about that. And this was, I think, the most impressive thing that I've seen that really shows there's a huge amount of overlap between these two conditions, and that they may very well, for the most part, be the same thing. Or it may be that to be diagnosed with true chronic fatigue syndrome may be a more severe version of what a lot of people who are diagnosed with adrenal fatigue have. So the point is, even though there are no adrenal fatigue studies, we can explore the evidence from 20 years of research examining the relationship between these three fatigue syndromes and adrenal health and cortisol levels. So with that in mind, let's keep in mind the fact that the adrenal fatigue theory can actually be tested. If the adrenal fatigue theory is true, or even mostly true, there are some basic predictions that come out of the theory that we should expect to find when we examine the research. So the first prediction is if poor adrenal function or low cortisol were the primary cause or a major cause of chronic fatigue, we should find that a large majority of people with chronic fatigue have low cortisol levels. Very simple prediction. You know, if that's the main thing causing it, we should expect to find that most people with that condition have low cortisol levels. Prediction number 2, if poor adrenal function and low cortisol were a cause of chronic fatigue, we should find low cortisol levels at the onset or early stages of the conditions. Prediction number 3, if they're a major cause or contributor to chronic fatigue, we should see a reliable relationship where cortisol levels relate to symptoms. In other words, the more severe the abnormality is in cortisol levels, the more severe the symptoms should be. Prediction number 4, if cortisol levels were the major causal factor in chronic fatigue, we should see a reliable relationship where as symptoms improve, so do cortisol levels. And prediction number 5 is if they were the major cause of chronic fatigue, then raising cortisol levels should improve symptoms dramatically, as it does, of course, in true adrenal insufficiency or Addison's disease. So if, in other words, low cortisol is really the actual thing causing these symptoms, if we then fix the cortisol levels, we should fix the symptoms. So these are 5 predictions. I'm sure that all of you would agree these are very simple predictions that we should expect to find if we examine the research related to this. So please keep these 5 predictions in mind because what you're about to find out is that the research doesn't actually validate any of these predictions. So, is adrenal fatigue real? Here's the answer from 20 years of research examining the cortisol and fatigue link. And again, this is essentially the entire body of scientific research examining this question. These are all of the studies. So I want to point out, I'm not cherry picking the research to prove some theory. I'm showing you all of the studies, including the minority of the studies which do show abnormal cortisol levels. So this is important because I just want you to understand, I have gone to such amazingly great lengths, literally tortured myself with just countless months to find, every last shred of a study that could possibly even be remotely relevant to this question. And I've put all of those studies in this review. So with that said, I'm giving you kind of the brief overview of what you're about to see, but let's actually look at this evidence. And I'm going to take you through this. This is over 80 studies, 60 individual studies, and 20 systematic literature reviews. So obviously we don't have time to go into the details of every study. Otherwise we'll be here for about 20 hours. But this is just a table where I've compiled all of these results. So let's see if I can get this to a one-page view. There we go. Okay, so here's all the studies, and I've done this by date starting in 1995. No differences in cortisol between those with chronic fatigue syndrome versus normal healthy people. No differences, no differences, no differences. Lower morning cortisol, lower cortisol. No differences, no differences, no differences. Slightly higher cortisol in people with chronic fatigue. No differences. Slightly higher cortisol in people with chronic fatigue syndrome. Higher morning and afternoon cortisol in those with burnout versus normal healthy people. And you can see I've actually screenshotted the actual graphs from these studies wherever they gave them. So those are in here as well. Lower morning cortisol in those with burnout, normal urinary cortisol levels in people with chronic fatigue syndrome, lower cortisol in people with chronic fatigue syndrome versus normal. No difference, low cortisol in people with burnout, but symptom improvement, recovery from burnout doesn't correlate with any changes in cortisol levels. Higher morning cortisol in those with burnout. So you can see, literally from one to the next, they're contradicting each other. Here's burnout, burnout, burnout. One says normal cortisol levels in people with burnout. One says low, one says high. So this is, that's like a little microcosm of what the overall body of evidence shows. Fatigue not related to cortisol levels. At the end of 6 months of cortisone treatment, hydrocortisone and fludrocortisone treatment, no differences between treatment and placebo in patient-reported fatigue or well-being. Higher cortisol in fibromyalgia. The same study found lower cortisol in chronic fatigue syndrome. So and this is in one individual study, two syndromes which share many of the same symptoms one has higher cortisol and one has lower cortisol. And keep in mind, these differences are often very slight. It's not massive difference where one's producing huge amounts of cortisol, the other one's producing almost none. We're talking about minor differences relative to normal healthy people in cortisol. Here's another one. Only very slight differences in cortisol in those with chronic fatigue versus normal healthy people. Concluded that cortisol is a poor predictor of symptoms like fatigue. Another one, we're in 2005 now, so we just went through 10 years of research. No change in cortisol accompanied the symptom improvement. Here's the morning cortisol salivary response in burnout. And by the way, these are all the study names here on the left. So if you care to look any of these up, you're welcome to. Higher morning cortisol levels for women with burnout, higher morning cortisol for males with moderate burnout, but people with severe burnout didn't differ from normal healthy people. So in one study, they found higher for mild burnout, but for the people with the most severe burnout, they actually had normal cortisol levels. No differences in cortisol between burnout and normal healthy people. HPA axis functioning in clinically diagnosed burnout patients as tested in the present study seems to be normal. No difference in people with burnout versus normal healthy people. And this is a cool study we'll talk about later in another section where they actually tested cortisol on work days versus non-work days. And that's relevant to something we're going to talk about later. Burnout syndrome, no difference in cortisol versus normal healthy people, lower morning cortisol and normal cortisol at all other times of the day. Here's one of the few intervention studies that was a longitudinal study. This was an 8.5 month intervention study that found that recovery from burnout has no relationship with cortisol changes. They actually mapped out the cortisol levels at baseline and after 8.5 months of treatment and follow-up. They found that people recovered symptomatically, but that this did not parallel any changes in cortisol. Higher morning cortisol in those with burnout. Again, I just want to point out from one study to the next, there's massive contradictions here. One study says low, one study says normal, the next one says high. This is every different year that this goes by, we see these same contradictions emerging in all the research. Lower morning cortisol in those with severe burnout. Again, if I go back to that one that we just looked at, it found that the people with the most severe burnout had actually normal cortisol. So again, contradictions from one study to the next. No difference in people with burnout versus normal healthy people. Here's one on adolescent girls with severe chronic fatigue. No difference in morning cortisol between girls with and without severe chronic fatigue. Here's the chart. No difference in cortisol between people with clinical burnout versus normal healthy people. Lower morning cortisol and higher evening cortisol in those people with chronic fatigue syndrome. No significant associations between cortisol and burnout. Women with chronic fatigue syndrome had lower morning cortisol. Men with chronic fatigue syndrome had higher morning cortisol. In the same study, they're finding that the same symptoms can emerge in different people, but depending on which sex you are, you may have higher or lower morning cortisol. No significant differences, higher overall cortisol in those with fibromyalgia. Burned out people did not show different morning cortisol levels. Cortisol levels did not change during treatment when people actually got better. Researchers concluded morning cortisol is not a valid marker for stress-related exhaustion. And this is one of the best intervention studies, long-term follow-up of cortisol awakening response in patients treated for stress-related exhaustion. It's one of the few studies that have done an intervention and actually treated people, had them recover significantly, and then measured cortisol levels. They concluded cortisol is not a valid biomarker for stress-related exhaustion. Mild low cortisol levels, grouped people into different subtypes of burnout and found slightly different cortisol profiles for slightly different subtypes. No differences in cortisol, higher cortisol in those with burnout, dramatically higher cortisol levels associated with more severe scores on adrenal fatigue assessments. This is one of the only studies that has actually been done on that actually uses the term adrenal fatigue, and they found dramatically, massively higher cortisol levels associated with more severe scores on their adrenal fatigue questionnaire. Again, that's important to point out because the claim is often that adrenal fatigue is low cortisol, and many of these other studies are trying to claim that it's low cortisol that they're finding. Low cortisol for women, low morning cortisol for women with burnout, lower overall morning cortisol for men, but higher cortisol upon awakening. No significant differences, improvement in symptoms, but didn't correlate with any change in cortisol. Intervention study in people with fibromyalgia that created big improvements in symptoms, but those improvements did not relate to any changes in cortisol. Slightly higher morning cortisol in those with chronic fatigue syndrome. No difference in baseline cortisol levels between chronic fatigue syndrome versus normal healthy people. So again, so that's all the studies. That's 1995 to 2017. So you see that almost every study is contradicting the next one. I mean, there's just a massive amount of contradictions here. There's also a number of, so these are all the individual studies. And then there's also 20 literature reviews. I'll spare you from going through all of those individually, and we'll just sum it all up right now so we can get moving here. Basically, here's what the overall body of evidence says to sum all of this up. So 80 studies over the last 20 plus years that have examined the link between cortisol levels and chronic fatigue. 16 of 60 studies give evidence for lower morning cortisol levels in people with chronic fatigue or fibromyalgia or burnout syndrome. 12 give evidence for higher morning cortisol levels. 32 of 60 studies show no significant differences in cortisol levels in people with chronic fatigue syndrome or fibromyalgia or burnout syndrome. The vast majority of studies show there are no differences. Okay, so you can take somebody with severe chronic fatigue syndrome, debilitating fibromyalgia, totally exhausted from work, you can compare them to a normal healthy person, and the vast majority of the time, for the vast majority of people with these debilitating conditions, you will find zero indication of an abnormality in HPA axis function or adrenal function or cortisol levels. Evidence from the intervention studies. There's 10 intervention studies overall. 3 of the 10 studies showed a connection between cortisol increases and improvement in symptoms. 7 of the 10 studies showed no connection between improvement in symptoms and cortisol levels. And evidence from 20 literature reviews. The majority of reviews conclude exactly basically what I just showed you. There are inconsistent and contradictory findings. The most common cortisol abnormality is in the direction of lower cortisol, as I just showed you here. About 16 of 60 give evidence for lower, 12 of 60 give evidence for the opposite cortisol abnormality. So technically, the lower morning cortisol levels have been found more commonly, but it's important to keep in mind the vast majority of studies show that the vast majority of people have no cortisol abnormalities. There was one study in chronic fatigue syndrome, a review of the literature, that gave actually stats on this, and they said that 1/3 of studies find evidence for low cortisol in roughly 1/3 of people with chronic fatigue syndrome. So in other words, I'll phrase this differently. 2/3 of studies find people with chronic fatigue syndrome have normal cortisol levels. There's no significant differences. And 1/3 of studies find that 1/3 of people with chronic fatigue syndrome have some kind of cortisol abnormality, usually in the direction of lower cortisol. And we're going to talk more about why that is later. The majority of the reviews conclude that findings are contradictory and inconsistent. The most common abnormality in the direction of lower cortisol. There's no specific cortisol pattern or change in HPA axis function that is unique to chronic fatigue or burnout. In other words, this same exact abnormality in cortisol patterns, whether we're finding people with the high one or the low one, or particular patterns of how the HPA axis functions, is not in any way unique to chronic fatigue syndrome or burnout syndrome or fibromyalgia. These same exact cortisol abnormalities can show up in dozens of other unrelated conditions with totally different symptoms. And finally, the majority of people with chronic fatigue, burnout, have no adrenal HPA axis dysfunction and have normal cortisol levels. The majority of people. And I know I keep emphasizing it, but it's really important to understand that. So summary of findings, the overall evidence, body of evidence is contradictory. Cortisol, HPA axis dysfunction, even when it does occur in a subset of people, are not present at the onset or early stages of the condition. There's no specific change to the HPA axis or cortisol levels in either chronic fatigue syndrome or burnout. There's a lack of longitudinal evidence from intervention trials that links cortisol changes to either worsening or improvement of chronic fatigue syndrome. The majority of people with chronic fatigue and burnout appear to have perfectly normal cortisol levels. Here's the best estimates of the percentages. Roughly 20 to 30% of the overall population with chronic fatigue syndrome have low cortisol levels, 10 to 15% have high cortisol, and 65% or more of people with chronic fatigue syndrome have perfectly normal cortisol levels. So what that means is there's no relationship, no reliable, predictable relationship between a person's cortisol levels and whether they have this syndrome, whether they have this cluster of symptoms or not. A person with two people with that same exact cluster of symptoms who are at the same exact severity and level of being debilitated, one may have high cortisol, one may have low, or we'll take three people, and one may have normal. Or I guess to say it more accurately, if we take 10 people, the majority of those people, let's say 6 or 7 of those people will have normal cortisol, 1 to 2 will have high cortisol, and 2 to 3 might have low cortisol. So let's look at some of the most telling studies. And this was an interesting one where they divided nurses into 3 groups based on their cortisol levels: extremely high, normal, and very low. They found that subjects grouped on the basis of extreme cortisol values did not differ in the amount of stress, coping, or psychophysiological complaints, like, for example, fatigue. So they found no relationship whatsoever between the symptoms and whether someone was at the extreme of high cortisol or the extreme of low cortisol. The neurobiology of burnout. This is a review of the literature. They concluded the pioneering studies that focused on the relationship between burnout and dysregulation of the HPA axis have yielded inconsistent results. Data from subsequent studies with improved designs suggest there is no HPA axis dysregulation in burnout. When taken together, among all the studies that investigated HPA axis function in burnout, 3 supported increase in HPA axis functions in burnout, 5 support a decrease in HPA axis functions, i.e. low cortisol, and 11, again, the majority of studies did not support that there is any difference in cortisol levels between people with burnout versus normal, healthy people. And you'll see their percentages, interestingly enough, even though they were just looking at the research on burnout, really match up well with the overall body of evidence looking at all these different fatigue syndromes. The HPA axis and the genesis of chronic fatigue syndrome. This is another one of the best literature reviews that has been done on chronic fatigue syndrome specifically. And so this is an important line because they actually looked to find out whether they looked in high risk cohorts, high risk groups of people that they know are very likely to have a portion of those people, a high portion of those people who end up with chronic fatigue syndrome. And they looked at the cortisol levels in all of those high-risk people. And what they found is that whether a person had normal cortisol or low cortisol or high cortisol, whatever cortisol, did not predict whether a person was going to get that condition or not. So in other words, they're trying to assess, is there some kind of cortisol abnormality that is present in the onset or early stages of the genesis of chronic fatigue? And what they found is there was no relationship. And that's pretty cool, because this is one of very few studies, if not the only study, that has actually looked at this. Again, this is the same study, the same literature review. In summary, evidence suggests that although there is HPA axis disturbance present in subjects with operationally defined CFS, it is not present before the onset of chronic fatigue syndrome or during the early phases of illness, but develops once the illness has taken a more chronic course. A reversed direction of causation, i.e. that the illness itself leads to HPA axis change rather than the other way around, is supported by the findings that there's an apparent absence of HPA axis changes early in the genesis of chronic fatigue states, and that modifying cognitive behavioral components of the illness leads to a normalization of the HPA axis. So in other words, they're saying that some of the factors that arise in the illness itself will cause the HPA axis changes. And there are no HPA axis changes or cortisol abnormalities at the beginning or early stages of the condition. Therefore, you can't really claim this as a cause, quote unquote, of the condition. So let's look at more problems with adrenal fatigue. There are several more problems with this condition. Here's the first one. Cortisol testing has 4 problems just as far as how the testing is done. Tests that don't give the full picture of cortisol amounts are used commonly. Tests are often administered only once by some people. Some functional medicine labs have revised their reference ranges in a very narrow range. And 4, tests are often not administered at the correct time. Second big problem with adrenal fatigue, biomarkers have to be consistent to be scientifically valid. If a potential biomarker is not reliably associated with a specific condition, then it is not a valid biomarker. Simple as that. Let's just put this in different terms so that we can think about this in a more clear-headed way. Let's say you're looking for a biomarker of insulin resistance, and you analyze the blood sugar levels of thousands of people with type 2 diabetes and found, and this is just a hypothetical example, this is not what we'd actually find, but I'm just trying to illustrate a point here. Let's say you found that high blood sugar that people with insulin resistance and type 2 diabetes had high blood sugar 25% of the time, had low blood sugar 25% of the time, and had normal blood sugar 50% of the time. Okay. What would immediately happen in this scenario? They would throw out the biomarker. This would immediately be recognized as a scientifically invalid way of assessing whether somebody has type 2 diabetes or insulin resistance. It's invalid. It's simple as that. And the crazy part is that this is exactly what's going on in the whole realm of adrenal fatigue, chronic fatigue, burnout syndrome. People are trying to use cortisol levels as a biomarker for this condition. And they're trying to say, oh, we measured your cortisol, and this is, very scientific. We found that you have this cortisol abnormality, therefore it means you have this condition. Well, again, as I've already showed you, the majority of people with those conditions actually have normal cortisol. And then the people with cortisol abnormalities have different cortisol abnormalities. There is no consistent cortisol abnormality that is associated with these conditions. Moreover, the cortisol abnormalities that do sometimes appear in a subset of people with chronic fatigue also appear in many other unrelated conditions. So you simply cannot use this as a valid biomarker of chronic fatigue syndrome or burnout syndrome or stress-related exhaustion or fibromyalgia. This is not a valid biomarker. Now, there is no other condition in the world where people would insist on using a diagnostic marker for a condition that the research shows is so inaccurate and inconsistent. This would immediately be recognized as an invalid biomarker and discarded. And yet we still, so much of especially the holistic, naturalistic, functional health practitioners are focused on cortisol and cortisol measurements and HPA axis as if it's so significant and so diagnostic of these conditions, and it's just simply not. Problem number 6, the hormonal pattern that is present in adrenal fatigue does not actually indicate fatigue or burnout of the adrenals. What the hormonal pattern indicates is that the body is intentionally lowering cortisol levels, not that the adrenal glands are fatigued and can't produce enough cortisol. So here's what I mean by this. This is the HPA axis, hypothalamus, pituitary, adrenals. We know that there's feedback loops that occur here. And basically, if we're in a situation where the adrenals are not producing enough cortisol, what that will do is it will basically feed back up here into the hypothalamus and pituitary. The hypothalamus and pituitary will sense, hey, we don't have enough cortisol, so let's produce more CRH, let's produce more ACTH, and then that will stimulate the adrenals to produce more cortisol. Now, in Addison's disease, true adrenal insufficiency, what we see is exactly what we'd expect to see. We see lots of ACTH being produced, very high levels of ACTH. So the brain is calling for the adrenals to produce more cortisol. But in true adrenal insufficiency and true Addison's, the adrenals are actually not capable of producing enough cortisol. So what we see is very high ACTH and very low cortisol. And what that means is that the brain is screaming at the adrenals, produce more cortisol, but the adrenals can't actually do it. So the question is, in people with chronic fatigue, do we see that kind of hormonal pattern? And the answer is no. We do not see elevated ACTH levels, and I've already shown you that the majority of people with chronic fatigue actually have normal cortisol levels. So we don't see this pattern of high ACTH and low cortisol. Moreover, and I'll get to this in a second, raising cortisol with hydrocortisone to normal levels should produce dramatic benefits, just like it does in true adrenal insufficiency and Addison's disease, and should not suppress the body's own production of cortisol levels. And it doesn't actually do that. We know that in people with chronic fatigue syndrome, it doesn't produce dramatic benefits, and it does suppress the body's own production of cortisol. In other words, in the subset of people with lowered cortisol levels, it appears that the body is intentionally lowering cortisol levels to that level. It does not appear that the brain is screaming for more cortisol to be produced and the adrenals are just not capable of producing it. We do not see that same pattern of adrenal insufficiency in people with chronic fatigue or who suspect that they have adrenal fatigue, who are often diagnosed with adrenal fatigue. That pattern is not there. So why would the body be intentionally lowering cortisol levels? And this is a bit of a digression, just in case you're skeptical of this idea that the body would want to lower cortisol levels, and you're kind of more familiar with a paradigm that says the only reason for low cortisol would be that the adrenals are not capable of producing it. There are actually many reasons that have lots of science to back them up for why the body would be producing less cortisol levels. Number one is to allow the body's immune and inflammatory system to function in the face of threats. And this was a fascinating study from just about a year ago in 2016, so very new study, specifically looking at whether the HPA axis changes are the cause or consequence in people with chronic fatigue. And they're looking at, is the HPA axis change coming first, or are the immune and inflammatory and oxidative and nitrosative damage pathways occurring first? And what they found was that the downregulation of the HPA axis in the face of a chronic inflammatory document is well documented. The HPA axis becomes hypo-responsive following prolonged exposure to the cytokines, and this adaptation occurs relatively quickly. The stress crash theory that HPA axis hypofunction drives the activation of immune inflammatory pathways in myalgic encephalomyelitis and chronic fatigue syndrome cannot be validated. This theory is contradicted by a number of findings, including the HPA axis hypofunction is only present in a subgroup of patients, i.e. it's not present in the majority of people, as I've told you. There are no changes in HPA axis during the early stages of CFS, as I've already told you from the study on the genesis, the literature review on the HPA axis and the genesis of chronic fatigue syndrome, and C, the immunosuppressive effects of glucocorticoids are enhanced in CFS. So, on the contrary, we propose that HPA axis hypofunction in CFS may be explained by a number of mechanisms, namely chronic inflammation, HREG response. They go into increased activity of oxidative and nitrosative pathways, and D, the effects of infection-related mechanisms that can downregulate HPA axis activity, such as lipopolysaccharide tolerance and viral infections. So what they concluded is that the HPA axis changes in the subset of people when they actually do occur, which they're not occurring in the majority, occur as a consequence of inflammation and oxidative and nitrosative stress, and maybe some infections and some of these other cytokine and immune changes. Number two, another potential way that the body may lower cortisol levels that does not rely on the concept of adrenal fatigue. It just has a simple consequence of poor sleep and certain lifestyle factors. And we'll talk more about this in a second. But this was the HPA axis and the genesis of chronic fatigue syndrome. They found that the HPA axis changes can be reversed by modifying behavioral features of the illness, such as not being sedentary, and not being physically deconditioned, and fixing sleep patterns. So as soon as you fix those things, you fix the HPA axis, but you don't necessarily fix the chronic fatigue. So again, this is why they concluded that there's probably a reverse direction of causation, meaning the HPA axis is not causing the chronic fatigue in the first place. It's likely a consequence of some of these things like sleep disturbance and being sedentary. This is another one, and we're going to talk more about the different factors here that lower morning cortisol. We're going to talk more in depth about that in a minute, so I won't go into that right now. As a way to facilitate the body's healing response, and this is more speculative, not a lot of research really backing this up, but definitely a lot of practitioners kind of are under the impression that the body may just kind of downregulate the gearbox, as Sarah Myhill calls it, of cortisol levels to just kind of facilitate healing. And, you know, as Sarah Myhill puts it, this is kind of part of, fatigue is part of the body's downshifting to protect the body. The body's downregulating kind of all metabolic functions, all energy production as part of this protective response, and fatigue is a symptom of that. So that's one idea, again, speculative, not really science-backed, but interesting nonetheless. And then just as part of the body's downregulation of many physiological systems in chronic fatigue. And this meshes well with the last point, but Robert Naviaux's research at the University of California, San Diego. He runs a lab for mitochondrial medicine, and I believe he's doing some of the most important research in chronic fatigue and in overall chronic disease in the world right now with this concept of the cell danger response. But we won't get into all of that right now. This was a landmark study where they did a metabolomic study. They assessed over 600 metabolites, 612 metabolites in people with CFS, and they found abnormalities in 20 different metabolic pathways. They found that 80% of the diagnostic metabolites were decreased. So there's a huge amount of biochemical abnormalities in people with chronic fatigue. And specifically, they're finding that most of these metabolites, 80% of them were decreased, were downregulated. So part of this, as Naviaux explains, is that there's a whole metabolic downshifting that occurs. Basically, the body's going into kind of a hibernation mode as this protective response. Again, meshes well with Sarah Myhill's work, Interestingly enough, when I interviewed Sarah Myhill on my podcast several months ago, I was shocked to learn that she was not familiar with this research, and I actually said, you need to go look at this because it meshes so well with what you're doing. Basically, what I'm suggesting here is it's very possible that low cortisol levels may just be one of many, one of the 80% of these different metabolites that are being downregulated. Problem number 7 with adrenal fatigue. Many common factors can cause cortisol abnormalities. The same exact cortisol pattern that is claimed by some to be associated with chronic fatigue or burnout is also found in people who are simply overweight, night owls, people on antidepressants, at least some types of antidepressants, and many other types of medications impinge or affect the HPA axis, and simple sleep deprivation. Basically, the same exact cortisol pattern can be caused by some of these factors, and some of these symptoms are, some of these things actually emerge as symptoms of chronic fatigue. This is the Neuroendocrinology of Chronic Fatigue Syndrome, a literature review. There is no convincing evidence that any HPA axis changes are specific to chronic fatigue syndrome or are a primary cause of the disorder, rather than being related to the many possible consequences or corollaries. And what those are: excess body fat. Here's research into that showing as you get more overweight, your morning cortisol levels get lower. And this is just basically an adaptive response to being overweight. Night owl chronotype. If you're a night owl, you will have a lower morning cortisol awakening response. Simple as that. You don't need chronic stress to be burning out your adrenal glands. Just being a night owl or going to sleep later will cause this same cortisol abnormality. It's just the research on showing the link between morning cortisol and being a night owl. Lots of studies have been done on this. This is another study basically showing, I put this here just because remarkably, it's showing nearly twice as much cortisol. So a huge difference in cortisol levels between just people who are morning types versus evening types. This isn't in people with chronic fatigue syndrome. This is just if you're an evening type, if you're a night owl, you're going to have way less morning cortisol. So this is a factor that isn't controlled for in virtually all of these cortisol testing. And I've never heard anyone even mention this. And yet, as I just showed you, there's a whole bunch of studies showing that this happens. I've never heard any practitioner or any study control for virtually any of these variables in trying to link cortisol levels between cortisol levels with chronic fatigue. Night eating, just simply eating at night, will reduce your morning cortisol levels. Antidepressant use. Here's another screenshot from a study showing in people who are depressed, stress-related exhaustion. They have the same exact stress-related exhaustion condition. They got the same symptoms, but only the group on antidepressants showed low morning cortisol levels. So, just ask, is the cortisol pattern causing the condition, or are the antidepressants causing the cortisol abnormality? I'll let you decide, given all the evidence, all the layers of evidence I'm showing you here. Being sedentary, this is another one. Activity level is frequently used to study circadian rhythm. Lower daytime activity and less regular activity rest cycles in persons with chronic fatigue than in controls. So, and we know that activity is also correlated with flatter diurnal cortisol profiles, meaning lower morning cortisol, higher evening cortisol, which is what's claimed by some as adrenal or HPA axis dysfunction. They talk about it in terms of these brain systems, these glands being the cause of the condition. But what I'm suggesting is these things may simply emerge as an immediate consequence of somebody who's simply inactive, or somebody who's simply overweight, or somebody who is simply a night owl. They will cause these same exact abnormalities. Here's another one: having a day off of work instead of working. They looked at the same exact people, group of people with burnout. They measured cortisol levels on work days. They found they're up here, high cortisol, high morning cortisol awakening response, and then measure the same people when they have a day off of work, and you get low cortisol. So the point here is this abnormality is not just caused by chronic stress, this idea of adrenal fatigue, chronic stress wearing out our adrenal glands so they can't produce enough cortisol. It's modified from one day to the next, simply depending on what are your demands on that particular day. And this is another huge confounding variable in a lot of these home cortisol tests that people are asked to do, because are they measuring their cortisol levels on a work day or a non-work day? Again, another confounding variable that is not being controlled for. And it's a confounding variable for two reasons. One is what I just mentioned. If they do at-home tests on non-work days, they're going to have lower cortisol than if they do it on work days. And then the other reason is that patients with severe chronic fatigue syndrome, those groups of people will have more non-working persons in them. So these studies that are trying to assess cortisol levels in people with chronic fatigue versus normal healthy people are confounded by this fact that, a lot of these people are basically measuring cortisol levels when they don't have daily demands on them that morning to go to work, whereas people without the normal healthy people may be going to work that day. So, and just another confounding variable that's not being controlled for. And here's probably the biggest one: poor sleep or lack of sleep. Lots and lots of studies show that simply poor sleep or sleep dysfunction or just lack of sleep, not getting enough hours of sleep, will cause the same exact cortisol abnormality, lower morning cortisol, flatter diurnal cortisol curve, as is seen in some subset of patients with chronic fatigue. Here's one that showed nighttime work caused the same exact neuroendocrine abnormalities reported to be characteristic of chronic fatigue syndrome. And they're saying these neuroendocrine abnormalities may merely be the consequence of disrupted sleep and social routine. Now, here's the data. This is from several different studies, and overall, from all the studies, we know that roughly 50% of people with chronic fatigue have some type of sleep disorder, actually diagnosable sleep disorder. One study found that more than 50% of chronic fatigue patients have either obstructive sleep apnea or sleep-related movement disorders. Another one found 46% of people with chronic fatigue syndrome have obstructive sleep apnea. Another one found nearly 80% of people with chronic fatigue syndrome experience unrefreshing sleep, and 20% had either narcolepsy or obstructive sleep apnea. So the point being, this is a huge confounding variable when you're trying to link cortisol levels, and you're trying to assess cortisol levels in people with chronic fatigue syndrome versus normal healthy people. Well, the incidence of poor sleep and sleep disorders are way, way, way higher among people with chronic fatigue syndrome versus normal healthy people. And we know that poor sleep will cause low morning cortisol, will cause these cortisol abnormalities. So just more research on this. Systematic sleep restriction appears to alter the peak cortisol secretion after awakening, resulting in a lower peak cortisol secretion after sleep restriction compared to unrestricted sleep. Point being, these changes are not due to chronic stress burning out our adrenals and preventing them from producing enough cortisol. This will happen from one day to the next. If you don't get enough sleep, one day to the next, the day after not getting enough sleep, you'll have low morning cortisol. The data supports the notion, this is from a study on burnout, the data supports the notion that sleep impairments are causative and maintaining factors for this condition. This is another systematic literature review. Inactivity, sleep disturbance, psychiatric comorbidity, that's another factor, confounding variable I didn't even mention because we don't have time. And medication use like antidepressants and ongoing stress experienced by people with CFS will affect HPA axis function. And the findings that HPA axis dysregulation is more prominent in patients with a longer duration of illness suggest that the endocrine changes may be secondary. Simply because the chronic fatigue burnout group of people will likely have more individuals that have these factors going on. They're poor sleepers, night owls, sedentary, on antidepressants, or they're overweight. These studies are very likely to conclude that overall, people with chronic fatigue or burnout have lower morning cortisol levels. Problem number 9, raising cortisol levels doesn't help most people with chronic fatigue get better. And this is one of the biggest problems with the whole adrenal fatigue theory. You can give people with fatigue extra cortisol and it doesn't fix their symptoms, and it can actually make them worse in the long run. So, again, one of the predictions that we talked about was that if low cortisol is truly the thing causing the symptoms, then raising a person's cortisol levels should resolve their symptoms, or at least reliably and predictably make most people better. And in fact, it doesn't. So this idea has actually been around a long time. It was popularized by a guy named Dr. William Jeffries when he wrote a book in the 90s or maybe even the 80s called Safe Uses of Cortisol. And this was even before the adrenal fatigue was coined in 1998. And Jeffries explained a concept called adrenal insufficiency period, which is basically the same thing as adrenal fatigue. It's too little cortisol. And he talked about it causing symptoms like this. And he presented his solution, which was to use hydrocortisone to raise cortisol levels to get rid of these symptoms. And the adrenal fatigue theory and all the HPA axis theories, the stress crash theories are really all kind of rooted in this line of thinking, and adrenal insufficiency period, adrenal fatigue, etc. According to Jeffries, the problem was too little cortisol. So the solution was administer synthetic cortisol, increase a person's cortisol levels. Pretty simple. And this is, in fact, a very simple way to test the theory of adrenal fatigue. If it's fatigued adrenals that aren't producing enough cortisol, that's the fundamental cause of these symptoms, then increasing cortisol levels should make people better. And we know that it does work that way, for example, in Addison's disease, true adrenal insufficiency. If you give people synthetic cortisol, it's, a life-transforming thing for them. It's not a subtle thing. It is life-transforming. And we know that these people need to do this, and it makes them way better. And there's no debate about that. So there are 3 studies that have actually tested this in people with chronic fatigue syndrome. This is study 1. This was and I'm going to go through them by date. So in study 1, significant improvement in 66.7% of patients taking hydrocortisone, which sounds kind of impressive until you realize 54% of patients on placebo also had improvements. So there was, and then the details of this are that there were small improvement in a rating of global health, quote unquote, but no significant change in fatigue for people taking hydrocortisone for 3 months. Study number 2, 34% of patients on hydrocortisone reported a significant decrease in fatigue, compared with 13% reporting decreased fatigue while on the placebo. And while some patients reported reduction in fatigue, the researchers concluded the majority of our sample gained little benefit from hydrocortisone. And finally, the most well-controlled study is this one, and the most recent study. And they did a crossover trial, 6-month trial, randomized placebo-controlled, double-blind crossover trial, 100 patients with chronic fatigue syndrome. And the crossover aspect is that the same individuals were put on both the placebo treatment for 3 months and the active treatment for 3 months in a double-blind fashion. And here's what they concluded. There were no differences between treatment and placebo group in patient-reported fatigue or well-being. And they also said, finally, chronic fatigue syndrome is thought to be a heterogeneous disorder, and treatment with low-dose steroids may only be effective for a certain subset of patients, like, for example, people with low cortisol levels. However, our treatment was not beneficial in patients with the lowest cortisol levels. So no difference with fatigue in the best controlled trial. And in addition to that, there's also many different potential consequences, side effects of doing this. I won't go through all of these, but there's many potential consequences of using these medications in people who don't actually need them or whose bodies don't actually want them. In particular, among all these potential consequences, which are common, like things like weight gain, Loss of adrenal responsiveness. When you suppress the body's natural cortisol output, it can be very problematic because now the body can become less resilient in the face of stress and more reliant on you artificially dosing the hydrocortisone or fludrocortisone or prednisone or whatever in response to stressors. The conclusion from all of this is clear. If raising cortisol levels back up to higher levels does not improve symptoms, then low cortisol levels are clearly not the fundamental cause of the symptoms in chronic fatigue. And the reason why administering cortisol-raising treatments is not standard practice in medicine for treating chronic fatigue and burnout is because the research doesn't support it. These tests that have looked at this were almost 20 years old. And we've tested this for a long time. This is not something that hasn't been tested. It's just that the research really didn't support it as being beneficial. And correcting cortisol levels has little, if any, impact on the symptoms associated with chronic fatigue, even in the subset of chronically fatigued people with low cortisol levels, the minority who actually have low cortisol levels. So the summary of all of this, to wrap up, basically 20 years of research into this has unequivocally failed to show any type of HPA or cortisol abnormality that is reliably found in people with chronic fatigue or burnout. The adrenal fatigue theory is not supported by the research in simple terms. And again, just to recap, vast majority of studies find no difference in cortisol levels at all between people with chronic fatigue versus normal healthy people. Cortisol levels are not a valid biomarker of fatigue. Cortisol level measurements are not a valid way of diagnosing people with fatigue. Cortisol level measurements are not a valid way of assessing the severity of fatigue. We know that people with severe debilitating fatigue may either have high, low, or most typically normal cortisol levels. We cannot predict the severity of their condition based on cortisol levels. Cortisol level measurements are not a valid way of assessing the cause of fatigue either. They tell you little to nothing about the cause of fatigue. They're not a valid way of directing the course of treatment. We know, for example, as I just showed you, that raising cortisol levels via synthetic cortisol does not actually improve symptoms for the vast majority of people. So it's not particularly useful for directing a cortisol targeted treatment to help people. A small subset of people, likely between 15 to 20%, have a lower peak in morning overall cortisol levels. This occurs in many different conditions and as a simple result of many different behaviors. As I've showed you, this is not unique in any way to chronic fatigue syndrome or to burnout syndrome or to chronic fatigue in general. Many other types of conditions with widely varying symptoms will have the same cortisol pattern in a subset of people at least. Cortisol testing has several different flaws and confounding variables. As I've showed you, the method of diagnosing people with fatigue based on cortisol levels doesn't stand up to scientific scrutiny. The whole concept of phases of adrenal fatigue is not validated by the science. The adaptogenic herbs often prescribed to people who have been told they have adrenal fatigue are only shown in the science to lower cortisol levels, not raise them. And this doesn't make a whole lot of sense if these people already supposedly have too low of cortisol levels. The symptoms claimed for adrenal fatigue are vague and generalized that are not actually unique to low cortisol levels or chronic fatigue. And the vast majority of people with chronic fatigue do not actually identify with the real symptoms of low cortisol levels. In the most generous scenario of giving some sort of importance to cortisol, it's possible that it's a perpetuating factor in the condition and may make recovery more difficult, but it doesn't appear to be a causal factor. Lowered morning peak in cortisol is something that arises in numerous different diseases and is not unique to chronic fatigue, as I mentioned. And the lowered morning peak in cortisol can be found in healthy, non-chronically fatigued people who are simply sleep-deprived, sedentary, on certain medications, or are just night owls. Cortisol level testing is useful, of course, for ruling out legitimate medical conditions like Addison's or Cushing's, but appears to be of little to no value in assessing or helping to direct treatment in chronic fatigue. Cortisol levels typically don't change in response to interventions that improve symptoms or normalize health. In 7 of 10 studies, remember the intervention studies, 7 of 10 did not show a relationship between cortisol levels and improvement in the condition. Raising cortisol levels doesn't fix it. Lower cortisol levels, when they do occur in a small subset of people, are almost certainly not the result of fatigued adrenals that are unable to produce cortisol, but the body seems to be intentionally keeping cortisol levels at that level. Abnormal cortisol levels are not present during the onset or early stages of chronic fatigue. Thus, wrapping up, poor adrenal function or low cortisol levels cannot reasonably be said to be a cause of these conditions, of chronic fatigue in particular. In short, cortisol level testing appears to be of little to no use in chronic fatigue, either diagnosing or helping to direct a beneficial course of treatment. Overall, in summary, the focus among many alternative or holistic or functional health practitioners on cortisol and the HPA axis as being the primary factor causing chronic fatigue appears to be unwarranted and extremely misguided based on the last 20 years of evidence. So that's the summary. I have no vested interest in anything as far as, proving or not proving the adrenal fatigue theory. This is just something that was, kind of became a passion of mine to figure out the answer to this. And as you can see, there is a very big mismatch between the amount of health practitioners talking about and focusing on the adrenals and cortisol and the HPA axis and the evidence, which simply does not suggest that this is playing a primary role in these conditions. So I hope that you guys enjoyed this presentation. It was a pleasure to give it, and thank you very much. And if you like any further information about what I do, feel free to go to theenergyblueprint.com or get in contact with me through that website. So I hope that this was insightful for you, and it was an absolute pleasure to give it, and take care.